Hi, continuing this series of conversations directed towards students and residents and colleagues at CGS Medical College, Bombay, Mumbai, and KM Hospital. Uh, we have had a few postings done. We are hopeful of having a few interactive sessions. Uh, the conversations are aimed towards discussing tools, clinical situations, and experiences that will be useful to uh, students, interns, and everybody else, whosoever is interested in their clinical lives. What we have noticed or since passing out is that the material that we do pass out is not good enough to survive uh, in the real world. This especially holds true after 5.5 years of training, after cramming and accumulating a litany of facts, most of which are not particularly well aligned with the real world. And this is by way of education of say about 15-20 years back. If things have changed, if things have improved, and things have become more relevant to routine life, that's great. But these conversations are intended towards towards channeling one's energies to collecting experiences which are going to be relevant and which are going to be useful not only to you but mostly to your patients and to the people that you will interact with, be it a first year student, a second year student, a third year student, an intern, or a houseman, or even a registrar. To some extent, the comment or the preceding comments do not apply to registrars or people in more advanced posts in fields wherein there is hands-on training, such as the surgical fields or gynecology, obstetrics, pediatrics, and but you know, I would beg to differ that the training and the interventions that are put forth in the thinking fields. That doesn't mean that the surgical fields are not thinking, but they are more doing rather than thinking. I'm sure the surgeons don't appreciate that comment, but the thinking fields do require certain alignment of one's thought process with reference to triage. From what I remember, Ward 20 or casualty, maybe the name Ward 20 has been changed to casualty, or the emergency room, requires triage. At KM, the triage in those days was being conducted by emergency medical registrar, emergency surgical registrar, the AMO, and there used to be coordination between these fields to decide what was best for the patient or what needed to be done next for the patient. We have certain views on the subject, and if the students and the interns have a better understanding and a better handle on how triage should be conducted, that would go a long way towards improving not only your clinical skills but what patients experience in casualty or what the patients experience in Ward 20. It would be a big help and it would be a big asset to the EMR and to the ESR. People can enlighten me as to the change in protocol there, if there is one. To give you a brief example, If we are talking about triage and somebody presents to the emergency room or to the casualty with shortness of breath, there has to be a triage protocol to figure out what needs to be done for this particular clinical situation. And um, the response would be varied between sending the patient for CAT scan versus sending the patient to the ICU, or sending the patient for a breathing treatment, or sending the patient for intubation, or sending the patient to the cath lab, or sending the patient home after routine examination. There could be a variety of other intermediate decision making processes or decision trees that could open out. But a fairly simple triage process could be conducted for a very common clinical situation that would present to the casualty, and the student should have a understanding or handle on conducting triage. So this is just a primer on the importance of triage, and triage would have to be conducted with all your other tools, meaning your history, which is a primary tool, then your examination, which is a secondary tool, and then the clinical testing, or lab testing, and that would be your guide for triage. We'll run a few examples of how triage could be improved given a given clinical situation. And as usual, we'll talk about a particular clinical situation today, and that will be knee pain. So the clinical history is knee pain. There are no other complaints. Excuse me there. Clinical history being knee pain. There is one additional piece of history which I would throw in, which is trauma. So given the history and the clinical presentation, you can ask your other questions as to the velocity of trauma, site of trauma, any other trauma, this, that, and other, to collect your historical facts. Going on to the examination, there are a number of videos that are posted for the examination of the knee, because the knee is a very commonly used joint, and because knee injuries are also very common. During your student days or during your training days and afterwards, you will have to encounter the knee very frequently. Therefore, you are well advised to have a working knowledge of the tests that go to evaluate the knee. And I will encourage you and urge you to look at those videos which have been posted from a number of sources for evaluation of the knee. To add my 2 cents to this particular clinical situation, once you have done your anterior drawer test, posterior drawer test, testing for your cruciate ligaments, once you have tested for your medial collateral ligament and the lateral collateral ligament, and once you have done your maneuvers to test the cruciate ligaments, the reason for doing those tests are to ensure stability of the knee joint and give you an indication as to which particular structure in the knee joint is affected. Many times in your clinical life, what you will find is that the patient has knee pain. This should not stop you, nor does it prevent you from doing all the tests that are required to test the integrity of the knee joint. Be gentle. You have to be gentle with the patient coming in with knee pain. Otherwise, if you start pulling at his knee to test the anterior cruciate ligament to do your drawer sign, it may be that you are exposed to risk of injury. On the other hand, if you do the test gently and the tests are designed in such a way that they can be done even on a challenged knee. When you see the videos, most of the patients are pretty normal. They are able to walk, they don't have a crutch, they have no swelling, they have no effusion, so they have very little pain. So the tests are done as if on a normal joint. But when you are talking about triage, you will find that the level of pain, the degree of pain, and the testing that goes with it will help you guide the patient as to whether he can go home and continue doing routine activities, or whether you have to direct him to the orthopedic surgeon, or whether you have to go and get imaging done before directing to the orthopedic surgeon. So those tests perform several functions. First thing is they let you know the integrity of the knee joint. They can be done on a painful joint. They are designed to be done that way. And third things, they help you with triage. Therefore, for the purposes of this video, I will encourage you to go through any of the posted videos for proper examination of the knee joint, determination of the effusion, pay attention to the mechanism of injury, common injuries to the anterior cruciate ligament, posterior cruciate ligament not so commonly injured. All the tests to be done to focus on the integrity of the knee joint, and the last caveat, once the testing is done, how those tests help you with triage, meaning selection of patient management and the decision tree related to that. Thank you very much for listening.